slides, so everybody feel good about themselves. So the question is if there's a role for single agent immune checkpoint blockers. And I divided this into two. Patients were previously treated and first line. So that's for everybody to feel good. Everybody knows this. Checkmate 17. Nivolumab was better than docetaxel in squamous. It was better than docetaxel in non-squamous, although the difference is not so great. Also, K-10, pembrolizumab was better than docetaxel, both doses. And the oak, atezolizumab was better than docetaxel. So everybody beats docetaxel. This is a 5-year estimate. 16% doesn't sound so good for non-small cell lung cancer, though it's not intention to treat. Out of 129, 16 were alive. But everybody keeps saying 16%. I'm just repeating it. But interestingly, there were patients among those long-term survivors of PD-L1 negative, patients of EGFR mutation, or sort of patients on that. So it's hard to predict which ones will survive, and it's very hard to deny some patients immune checkpoint blockers. So the first question is, should we use PD-L1 to select patients? For the checkmate 17, there was no way docetaxel will ever be better than nivolumab, regardless of PD-L1. But for non-squamous, it looks like PD-L1 positives did better than docetaxel. PD-L1 negatives did about the same. In the follow-up, long-term follow-up from the checkmate 03, PD-L1 negative patients, 5-year survival of 20%. I cannot believe there was a docetaxel that did that. So in the update, this is kind of important. Nivolumab did better than docetaxel regardless of PD-L1. As you can see, comparing the column bars, the difference here is not that nivolumab was better than docetaxel. Was better for squamous. Someone didn't like my comment. So yeah, so the idea is docetaxel is not as good for squamous. That's why the difference is so much bigger for nivolumab. The other story here is the keynote 001, the first keynote. I don't see much difference in outcomes for PD-L1 negative of 1 to 49, 50% or more did clearly better, but I don't see a difference in the graphs. So between 0 and 49%, not much here. Same thing for OAK. Even if you look at the, I know that the atezolizumab test is less sensitive, but if you look at TC0 and IC0, Tezo was better than docetaxel as well. So if everybody is better than docetaxel, it's hard to claim the docetaxel's role. So what are the alternatives to single-agent immune checkpoint blockers in patients who previously treated non-small cell lung cancer? So there's a lot of things being tried. Immune checkpoint blockers plus another immune check blocker, plus vaccines, plus androgenic drugs, plus chemotherapy, plus anything. You find a new drug, let's combine with immune checkpoint blocker to see if it's better. So this is the partial list, not comprehensive, of approved combination therapies with immune checkpoint blockers in patients previously treated non-small cell lung cancer. I didn't want to make this slide too busy, so just put the selected studies. None. So the first line setting is a little bit different. So looking at patients that have PD-L1 of 50% or more, everybody knows keynote was great. Pembrolizumab was better than platinum doublet. And in the follow-up, we see a median overall survival of 30 months, which is really unheard of. There are other options. The keynote 21 showed a response rate of 80% in those patients. In the checkmate 12, although only 13 patients, 12 responded. So maybe any type of immunotherapy will work here, and there's still room for improvement beyond single agent. But the key question here for first lines is that should we use them as a single agent in patients with PD-L1 less than 50%? This is the checkmate 12. The single arm, there are different checkmate 12s. So this is for single agent nivolumab. I don't see much difference here between PD-L1 less than 1% or more than 5%. More than 50%, clearly the best one. But looking at the 18-month overall survival, it's about the same. The numbers are small, but it doesn't strike me as much worse. And everybody knows Checkmate 26 was negative because nivolumab was not better than chemotherapy for patients that have PD-L1 more than 5% or more. But it wasn't worse either. So the curves are all together, and nivolumab is better tolerated than the platinum doublet in most of the cases. And patients with high tumor burden did better with nivolumab. This based on third trials, still needs to be validated. So are there alternative single-agent immune checkpoint blockers in first line? Yes, the Keynote 21. So the Keynote 21 was carboplatin pembrolizumab versus chemotherapy alone. There was a difference in PFS, but not in OS when it was reported. But the follow-up presented at ESMO showed that the curves are getting separated, and also, to me, it's amazing. The waterfall plot in red for the triplet. This is kind of target therapy waterfall plot. Looks more like a lymphoma than a non-small cell lung cancer. Something to consider. So the question of the title, is there a role for single-agent PD-1, PD-L1 inhibitors? The answer is yes. At least in second line plus patients advanced stage, regardless of PD-L1 status, and for first line, for patients with PD-L1 50% or more. Thank you very much.
Very good.